Today's meeting, I think, is to keep us all up to date. Everything changes on a daily basis. We're all trying to be sure that we're up to date on what's occurring, what kind of changes, and what the implementation issues are for employers and consumers and for the insurers.
How do you feel that the Affordable Care Act is affecting physicians in the area?
I think it's incited a certain amount of fear and concern about the cost of implementation. I think it's very scary to a lot of physicians. Physicians are considering leaving practice, and we're trying to educate our physicians into the reality of the ACA.
The ACA certainly has caused hospitals to really have a greater need to communicate with each other. And so within the Lafayette General Health System, which is now 11 hospitals in Acadiana, we've been really focused on investing in IT at all of our partners. I'm happy to say that this past year, 3 of the roughly 250 hospitals in the United States that were picked as most wired hospitals were from Lafayette General Health System. And so we're so excited about that honor. That honor is due to certainly our investment in our EMR, but it's also because of being an early adopter to LaHi. And I certainly believe that LaHi is going to be a central way in which we're able to communicate within our system as well as with other hospitals throughout our state. We need to know the test, the results, the outcomes that these patients have had in a variety of settings in order to be able to really drive down the cost of care to be a high-quality, low-cost provider.
How is the society working to educate these physicians and make everything work?
For our members, we have almost daily email communications about issues regarding medicine and healthcare delivery systems. We're making inroads into the medical schools where we're trying to get to medical students. We know that their curriculum is very tight, but we're offering them the availability of having lectures on the economics of medicine and the socioeconomic practice of medicine in the modern world.
Signed on March the 23rd of 2010, the Affordable Care Act was really reported to provide health care coverage to nearly all of us at a price we could afford, and we could keep the coverage that we had. Do all of us remember that comment? And this was the sort of Masonic mystery. This was the base upon which all of that was to be based. So let's quickly review what was intended. It was all about coverage. Anyone that suggests to you it was about trying to get costs under control, in fact, isn't looking at the bulk of the bill. It wasn't about cost containment. It assumed that employer coverage would continue. That was an important base upon which to build. That Medicaid would be expanded to take care of that large portion of the population that were very low income. And in many cases, the insurance industry was quite pleased to see that they essentially would be taken care of in a traditional way. And of course, millions were expected to secure coverage through the exchanges, people that were buying on the individual market and on the small business market. So the pieces, the big pieces of the ACA involved these things. The individual mandate, of course, assumed that the pools that would be created would be broadly representative, healthy, and non-healthy, which was critical to the insurance industry, to essentially have a product that could be priced for a broad pool of people. The employer shared responsibility, the pay or play. Again, the question was, and continues to be today, and that we're all examining, is it less expensive to pay or to play? And in fact, over the long term, what position do employers want to be in terms of the availability of coverage? They are an enormous part of the market today, the large employers in particular, but there's a question about what role small employers ought to play in terms of going forward. We hear about changes in spousal coverage. We hear about all sorts of things occurring, businesses getting out of the business of providing health care coverage. So what will happen over the long term, and we'll touch on this in a minute, remains uncertain. The tax credits, unclear the take-up. The one thing you don't hear about is how many small businesses have actually taken advantage of that tax credit. You had to be smaller than 25 employees. You had to have low-budget employees. It's only 2 years long, and starting in 14, you have to buy through the exchange. So how effective this is as a tool to really get small business in play, nobody really knows. It's like a lot of things we don't know very much about. Insurance market regulation, which I'll touch on in a moment, was at the heart of making coverage available and affordable, and was, in fact, the base upon which the administration really wanted to get people engaged. Having 3 children under the age of 26, I'll tell you, I was thrilled to hear that I could keep my kids on my policy. God bless them, someday they'll have real jobs, but don't know. My girls seem to be doing all right. My son's another story. But anyway, so all of those changes, readmissions and all those kinds of questions, no rescissions, pre-acts, and so forth. The insurance exchanges, the new market. The new magic solution to essentially grouping and allowing a market to exist through which people could buy coverage in an affordable way. The premium subsidies, again, linked to the exchanges. Interesting, this is an early Republican idea. I mean, that concept of essentially creating an opportunity for people to buy coverage is not something new. It is something we've talked about for a very long time. The size of the subsidy, to whom the subsidy will be given, is an issue we'll touch on. And then, of course, Medicaid was viewed as an enormous opportunity for expansion, a solution for the very poor, but got somewhat confused as a result of the Supreme Court decision. The individual mandate, again, critical to the insurance industry, assuring them that the exchange pools would be diverse, but the complaints about the penalties being too low. If I were to ask my son, in fact, I did ask my son what he thought of, buying private insurance and would he be willing to do that when the time came. And it was sort of a question between that and CAPS tickets. I mean, the sort of reality, he's a young invincible. He's, a young, healthy male, and, it's that or am I going to the CAPS games? Concerns that the exchange issues will discourage enrollment. That all these things that have arisen essentially in delaying people coming into the system, that the people that will be most resilient and willing to stick with it are the people that are sick, rather than essentially people that they want to have into these exchanges. So the question about the mandate, how effective it will be at $95, that versus whatever you're essentially going to have to pay, even with a subsidy, people will raise. So members are pushing to extend the enrollment period. The administration so far has resisted. They've taken it through March, but no further. There was a bill introduced yesterday by members on the Democratic side in the House to essentially delay the individual mandate. But of course, the concern then is that it will spiral even more in terms of who goes into the exchange. And again, if the exchange issues continue, my guess is we will see huge pressure to essentially delay that enrollment. The next big push was on the employer side. Unfortunately, again, we're yet to see what the real decisions will be. With respect to those up to 25, of course, no penalty. And they are, however, now incentivized not to hire the 26th employee. And we're beginning to see that. As we look at hiring over the last year or so, the real hires have been in part-time, not full-time, in terms of employment growth. With respect to the 24-hour or the 30-hour week as a definition of full-time, big pressure, pushback on how many people really think 30 hours is a full-time employee. So a whole host of people who are not going above 30 hours. So real impact on employment in that context. And of course, the goal is to maintain employer coverage, limiting the federal expense and cost. But the greatest uncertainty is around these mid-size employers. And are they, in fact, going to essentially step back and have their people go into the exchange, which is the only place they can get subsidies? A decision is from a business standpoint, as well as from an individual standpoint. Are my employees in better shape if, in fact, they go through the exchange, even if I pay the penalty? Is it going to be less costly for me? So we don't honestly know what's going to happen with respect to employer participation, and we're sort of all waiting to see how that will play out. I mean, there is a whole process in terms of penalties beginning after January of 2015. But the suggestion is, and I think it is a terrific one, and that is employers ought to be getting ready now in terms of what the expectation is, doing the calculations, and figuring out in their interest and in their employees' interest, what are the opportunities? How many of their employees have spousal coverage they can turn to? All of the kinds of questions in terms of the size and shape of their policy, and whether or not, in fact, that coverage is affordable. So those are all questions that we are looking at. The delay, obviously, came into play after a great deal of pressure about the complexity of employers looking at their plans, looking at whether they will meet the requirements. And again, we're beginning to see changes in behavior in terms of changes in the structure of the plans, increases in cost sharing, how many plans will ultimately end up being grandfathered that don't make changes. I think we don't yet know. So again, long-term questions of competitiveness, what makes sense for the employer, and essentially where are they going to go in terms of their coverage opportunities. There are a host of things in addition to the pay or play that also impact employers. So it is not as if everything has been pushed back. There are a host of benefit changes required, modifying policies to essentially meet the needs, developing a system to sort of track your employees and what happens so that if one of them goes to the exchange, at some point you have some indication that that's occurred. So again, from an employer standpoint, one can't assume that we've simply pushed it off. There are still a whole host of issues that people have to be concerned about. And then there are exchanges, the heart of the new market. We know what it is. We know what it's meant to do in terms of serving as an online marketplace for individuals, for small business, allowing people to apply for subsidies and for tax credits. The only mechanism to get a subsidy is, in fact, to go through the exchange. It's meant to increase portability so that people can move from plan to plan and employer to employer. Again, it is one that was designed as an opportunity. But what we've seen is extraordinary variation among the states in terms of how they've chosen to essentially approach this. The opening days of the exchange have left a lot of people quite concerned. Half the states, including Louisiana, opted for a federally run exchange. But even in the state-run exchanges, where they have the advantage of essentially, in some cases, having been ahead of the game, there are issues. Whether it's in Maryland is having issues, California is having issues. So the issues are not unique to the federally run exchanges. They're really across the board. And again, the governors will have an opportunity to rethink this. But initially, a number of them were concerned for a variety of reasons. It wasn't just about politics, which is, I think, what people would like you to think. It was really dependent upon a lot of other decisions. While admittedly the large majority of states with Republican governors chose not to operate an exchange, they did so for a host of reasons, some of them quite legitimate. Whether or not it's the infrastructure that was required, the upfront exposure, essentially what over the long term the federal government's commitment would be, whether they had the capacity to set in place these kinds of systems. But again, this is a decision that I think will come back. People will have another opportunity to look at it. I think they will look at the experience in both the state-run as well as in the federally run exchanges. I think they'll look at some of the partnership exchanges where there are states that have chosen to share with the federal government some of the responsibility. So again, I think the right choice will be uniquely independent of a political decision. It is in large part also a state decision in terms of what can and can't happen and what decision ought to be made. So I'm not assuming that what we saw on the map will remain static. I think, in fact, we will continue to see changes as states look at the opportunities and at the barriers that exist and whether they want to take back some of that control. What's interesting to me is even in the context of a federally run exchange, as is the case in Louisiana, when you ask the question of the federal government, of CISIO, about a host of things, and I'll touch on a couple. The answer is often, if an issue arises, where does someone go? And I'll talk about how this is a question of network adequacy. The answer, even in the federally run exchanges, is the state. CISIO is basically saying, well, that's really a state decision. That's really a decision that the state insurance commissioner has to make. So we can't assume that because it's a federally run exchange that there are still enormous responsibilities and issues that reside with the state. And again, the question is what that balance will look like over the long term. So the exchanges go live or not. Maybe not so live, as the case may be. There were enormous differences and difficulties leading to very low enrollment. Now, people will cite Massachusetts and say that the enrollment early on was quite slow, and that is in fact true. But the question is whether or not the problems can be resolved. We've been told November the 30th. Secretary Sebelius, suffered through 3.5 hours of a House hearing yesterday. Marilyn Tavenner earlier in the week, she did a terrific job, I have to say, all assuring us that it will be fixed. I think there is risk in giving a date certain. We saw a shutdown again yesterday. in terms of the hub. I mean, I think the complexity of these solutions, the integration of these systems, again, are going to be enormously challenging. The complaints that we hear in terms of information not coming back to insurers, not knowing, in fact, if someone's enrolled, if they've enrolled, what the data is on those individuals, which will have an enormous impact over the long term in your capacity to essentially price or anticipate what your product and what your market is going to look like. So again, the papers have been full about speculation about why the opening has gone so poorly. It's, I suspect, a whole host of things. I think it is not simply one. But the IT systems are clearly underlying an enormous amount. But the result has been a very slow take-up. These are data that came as late as about the 15th of October, so they're not recent as of this week. And no doubt these numbers will change over time. But again, the rising concern is that people will get frustrated and they will essentially stop. And even listening to people that are in strong support say, well, I had to go on 4 or 5 times and I just kept going back, gives you a sense of people who are not as familiar, people who don't have IT skills, don't have computer skills, are being told to call or essentially do a paper admission process. We all know that the terms and the complexity of that decision in terms of trying to decide, the inability to be able to anticipate price, when you looked at what was available to you, that decision I think was a poor one. So again, there's a question about sticker shock. When people finally see it and see the numbers, are they going to enroll? Some folks are seeing bargains, no doubt. Those that have been in the individual market and now have a product possibly available to them, but others are seeing a big price tag. So again, whether or not these picked a plan, actually enrolled, whether the data got through, people got the right subsidy. We're also hearing about the complexity in terms of calculating those subsidies, which is enormously different. And of course, then there's the question, if you get a subsidy and the subsidy is the wrong subsidy and you've gotten too much money, you're going to get a bit of a surprise at the end of the year. So again, I think all of these issues suggest that we are going to go through a very difficult time that I do not anticipate will end by November the 30th. I think it's clearly going to go into the new year, and from an insurer's or an issuer's standpoint, adds enormous complexity in terms of who it is that you're going to be dealing with and how best to manage those individuals. There are also a whole host of other kinds of issues that come up in the context of the exchange that we are only now beginning to hear about. This first go-round, what will they do in terms of looking going forward, whether you'll expand the opportunities. There are 4 plans on the exchange in Louisiana. Will you anticipate more? Will you anticipate fewer? What's that experience likely to be? But the issue I want to touch on in particular is the issue of network adequacy. Again, this is a question that I had reason to call CSIO and ask a question because I was contacted by a large public hospital that would just inform they were being left out of the network. There were only 2 plans in that particular county and they were being left out of the network. And so the question for them was, well, to whom do we complain? You know, where do we go? It's a federally run exchange. It's not, I will say it's not a Louisiana hospital. But where do we go, to whom do we complain, and on what basis do we complain? The answer was you go to the state. And so does the state have the infrastructure, essentially, and the decision-making and authority to essentially compel a plan to include a particular provider? We're hearing this discussion in Mississippi at the moment about the inclusion and a fight between the insurance commissioner and the governor as to who has authority. The insurance commissioner said, you know, we can't compel, and the governor said, yes, we can. So that will be an interesting conversation. But the issue of adequacy, again, large academic teaching hospitals, large public hospitals with big dish loads, hospitals that essentially are more costly than the local community hospital, are beginning to see, in some cases, being excluded from networks because of their cost. And as we see these tight networks forming, which is a tool that is available essentially to keep costs down, that issue, I suspect, will continue to arise. And then the question is, how broad is the network? Is it, in fact, adequate for the population that it serves? Are your federally qualified clinics part of it? Are your big teaching hospitals, your public hospitals part of it? Again, the tighter the network becomes, the tougher it becomes. And I think they will, the governors will, I can assure you, the state insurance commissioners will begin to hear from both consumers who now can't go to the hospital in close proximity or to the physician that they've gone to before, they're going to hear that kind of pressure. And then there's the reverse problem. In today's Wall Street Journal, a very interesting story about a psychiatrist who was notified that he was on 24 networks, 3 of which were dental standalone plans. Now, admittedly, I do take Xanax before I go to the dentist, but I don't think that's what he had in mind. But again, this whole desire for transparency, a desire for people to understand what's available to them, and then the implications of those decisions are going to have an enormous impact on how people perceive this as being a success or not. And then, of course, there's premiums. This is sort of an array of premiums in your sort of surrounding areas as well as Louisiana. And of course, these premiums are based on what we knew and what we thought would occur with respect to the pools. The question will be, what are these premiums going to be once we know what the experience is? And what will people begin to experience going forward? You have in place all of the rules about pre-existing conditions. You have situations if the enrollment and the exchange delays even further, people walking in the door at the last minute. There's nothing to prevent them from doing so. They can essentially go for 3 months without coverage, without a penalty, and presenting themselves. And so what do we know about what those rates are going to look like? We know there are medical loss ratios. There are lots of pressures downward in terms of premiums. But the question is going to be, what is going to be the reality of the experience in those exchanges? And what are people going to see in terms of the opportunity? And from the federal government standpoint, what does it mean in terms of subsidies? We know that we're looking at $500 million worth of subsidies now. What we don't know is what the reality of the subsidy will be depending on who goes into the pool and what the price is going to be. And so you're going to see continuing pressure if those subsidy desires and needs go up for us to look either at the population we're subsidizing. There are some people who think we ought not to have gone to 400% of the poverty line, that we ought to bring that number down. And then the question is, do the subsidies begin to decline, or do the cost of the federal government begin to increase? And then greater pressure on issuers to essentially bring those prices down. So all of these issues, again, we have no idea of enrollment, don't know what that mix is going to be. Insurance regulation, a huge part of what occurred. Again, all of the things you've all experienced, again, along with the coverage expansions, there were a host of insurance reforms that were put in place quite early. When we hear opposition to the law, to the ACA, it is interesting to me we rarely hear opposition to these provisions. And so the pushback is more about the Medicaid expansion, about the subsidies, about sort of the federal reach, but less about the insurance reforms, which have been in play and under discussion for years. So I would assume these would remain in place, even if, in fact, there were dramatic changes to the ACA. It is hard for me to imagine that any of these will really change over time as people essentially have come to accept them. Medicaid, another critical element of the coverage triangle. Again, like everything else, it depends on where you live. The decision on whether or not to expand a Medicaid program has been an interesting one in a number of states. It is obviously of concern to providers who are dependent upon and were hopeful for an expansion of Medicaid, particularly those that have heavy uncompensated care loads and dish loads, expected to see a big uptake. The Supreme Court decision obviously changed that. But again, while we see the political decision, or what appears to be a political decision, the decisions about a state's expansion or not is a complicated one. There are governors who are concerned that Medicaid, in fact, is not the right way to go, that it is, in fact, too structured, too challenging, too federally controlled, too bureaucratic. And there are those who are concerned about what their exposure will be over the long term. But in fact, what we've seen is this very interesting solution by Arkansas, and also being considered and put into place by Iowa. And that is a decision to do something other than expand Medicaid as we know it, but to use those subsidies essentially to buy private insurance, and to essentially get this Medicaid population into the private insurance market through the exchange. They're as interested in providing care to their citizens, but in a different way. And of course, what we don't know is what the long-term experience of this will be. What will it do to the pools in the exchanges? The bulk of these new enrollees are singles and childless couples who have not been covered by Medicaid in the past. So again, I suspect that the decision on Medicaid, as was the case at the outset of Medicaid, is not a final one. My guess is this will evolve. I think states, particularly given the Arkansas experience and the acceptance on the part of the feds, I think Arkansas will begin to rethink this. And I think it will have other governors essentially looking at this opportunity as well. Can we get them into a private market? Can we expand that pool and essentially protect ourselves? The Arkansas decision only goes until 16. That's how long their waiver exists. Iowa's looking to go to 18. But my guess is you'll have a lot of states that are going to be looking at this opportunity and looking for a chance to go forward. So I don't assume, nor should you, that the Medicaid decision is a set one in terms of population. Now, the thing that's interesting is that while we hear mostly about coverage, in fact, the ACA had a lot of other stuff in it. There were a host of issues in terms of delivery system reform, really largely demonstrations to begin to think differently about the way we finance services, provide services, organize services, big primary care interest and a bump in terms of primary care, a real desire to get people at the front end of that continuum of care rather than waiting at the back end, the development of health homes, better management of patients, looking at essentially state-based relationships with the feds around the dual eligibles, people that are eligible for Medicare and Medicaid. We've done a terrible job of managing that population. And then looking to the states for some of the innovation. And I think this will continue. The states have a tremendous number of opportunities. You are regulators. You are providers in many cases. You are purchasers, big purchasers. One example near and dear to my own heart, I have to admit, as a nurse, is the role of nurse practitioners. And that is whether we see an expansion in the use of non-physician providers, nurse practitioners and others, what those authorities are. Those are largely state decisions. Cost containment efforts, similarly. Notwithstanding the ACA, the states retain an enormous amount of opportunity. You know, whether it's requiring quality reporting, price measures to look at that. Obviously, insurance regulation, rate regulation still falls on the states. The design of insurance products, what the benefits are that have to be offered, notwithstanding the essential health benefit and the sort of 10 that are listed by the feds, the states still have tremendous authority to decide if they want to add or subtract from their own state mandates. Delivery system reforms. Again, are we using Medicaid managed care? 70% of the Medicaid population today is in some kind of a managed care environment. Issues, again, around patient safety. You know, are there new efforts to test new reimbursement models at the state level for either your Medicaid program or other incentives to get your providers to behave differently, to organize differently? Are there medical homes available? Are there places people can get managed? And are you looking to use more community-based, home-based care instead of institutional? Is that rebalancing occurring with respect to long-term care services? All of those are within the power of the state. And I think that's where a lot of the activity is going to take place. This is the implementation of the ACA. These are the things that were to have occurred in each year. There are big pieces of this that are state responsibilities and big pieces that are obviously federal responsibilities. This is what is supposed to occur next year. A long list of requirements, insurance exchanges, Medicaid, multi-state plans, the essential health benefits come into play, fees on the insurance sector. So there are a number of things that are going to go forward come January the 1st. While this battle rages over the exchanges and the implementation, there is no shortage of things that are essentially going to occur that are going to have an enormous impact on the way services are delivered. There are Medicare changes, things that are going to go forward. The decision to push back on readmissions and essentially to penalize. Efforts at bundling payments, an increasing interest in figuring out how do you manage somebody across a full continuum of care so that essentially you don't have these silos. Great pressure on hospitals, for example, to know where their patients go when they're discharged. what responsibility they have post-discharge to essentially monitor what's occurring or to coordinate with those post-acute providers. Great pressure on the post-acute side, on home health care, on hospice care, on nursing homes, to essentially develop those relationships. ACOs, a whole new vocabulary of essentially creations that are meant to do a better job at delivering services. So again, while the ACA was about coverage, there are in fact incentives to begin to rethink the way we do things and the way we organize and pay for things. The changes that are occurring essentially play at the state level in terms of new administrative responsibilities, enforcing new regulations, huge burdens on the state insurance commissioners that they have not had before. Tremendous responsibility essentially to be much more engaged. Big changes for consumers, for employers, in looking at affordability, at looking at purchasing, and the enforcement of the mandates, and even understanding the daily deluge of regulations that are coming out that define everything from hours worked, how to count employees, where their exemptions are, where they're not. Big provider issues, again, on the payment side, and of course, huge regulatory burdens on the federal side. The shutdown certainly didn't help that, but it certainly didn't stop it either. You are seeing, again, a new, huge role. So in conclusion, let's talk about the numbers. This is what we expected when the legislation was passed, that about 24 million people would ultimately go into the exchange. That remains to be seen. We expect about 19 million of those individuals to be subsidized through the exchange. We expect the subsidies to cost about $500 million, or $1 trillion. Forgot my B's and T's. We expected about 16 to 20 million new Medicaid enrollees. That remains to be seen. But one of the interesting things we've seen so far in these early days is that Medicaid enrollment is in fact going up. Not only in the expansion states, but just the increased knowledge and efforts to enroll currently eligible Medicaid beneficiaries. So we're seeing Medicaid numbers go up. We still, notwithstanding all of this, in an absolutely perfect world, we're still looking at 20 to 25 million uninsured. And they are uninsured for a host of reasons. They could be undocumented workers. They could be people for whom the affordability test removes them from the penalties. There are people that make that decision. There's my son who's buying CAPS tickets, who's not going to be left uninsured, I will assure you. The total cost of the program is about $1 trillion. Half of that came from taxes. The other half came from Medicare spending reductions. And it was assumed to be a debt benefit to reduce our deficit. Not clear whether that will be either, because a big chunk of that savings that was to go to essentially the deficit was the Class Act, the new long-term care, which we've subsequently repealed. So you can assume about a half to more than a half of that savings essentially has gone away. So, finally, how do we measure success, or how do we look at failure? I think these are sort of 8 ways that we can, over the coming months, both short-term, long-term, look at whether or not this huge exercise, this huge enterprise, has in fact been a success. Whether we've seen a reduction in the number of uninsured, whether we've increased or stabilized insurance premiums and the cost in the exchange and in the private market. Are there an adequate number of plans? Who's going to compete in these exchanges? Will people have choices? Will those increase or decrease over time? Will plans exit and enter, depending on the experience in the exchange? Does the number of people who pay the penalty for not having insurance increase or decrease over time? Which is to say, is it a benefit to them, in their view, or not, when they make that calculation in their own heads? Is there a decline in employer coverage? We're already anticipating about a 1% decline. The question is going to be whether we see more, whether employers essentially increasingly get out of the business. The change between full-time and part-time, whether we see a continuation of this question of, the 30-hour rule, or whether we expand the 30 hours. At what point does an employer make a decision to move somebody to full-time? The conflict between the state and federal government over the oversight of insurance. I mean, this has traditionally been a state-based activity, and now the feds are into it up to their necks. And the question is, over the long term, does that survive? Or do we essentially see a shift in power or a continued partnership going forward? And then, of course, is there an evidence of an increase or decrease in out-of-pocket expenditures? What do these plans look like? People may have access, but in fact, does the access translate into largely higher out-of-pocket costs, narrower benefits, narrower networks? And so again, as I said at the outset, we are in fact in very interesting times.
There are still hospitals all over Louisiana that still have that mom and pop sort of structure. And the way in which we have to be structured going forward in order to be successful is that if you think about it across the country, what has closed down mom and pop stores all over the United States? What entity? Walmart, absolutely. And so we are in the process of aggressively turning all of our hospitals that are in our system into Walmarts and turning the main hospital into a super Walmart. I try to keep things really simple. My staff loves it, they just don't know that that's just the way I think, but that truly is what we're trying to do. And so when you talk about being a Walmart, what does that mean? That means providing exceptional value and providing products and services at a very low cost. And so really paying attention to all of your metrics, your labor metrics, your supply metrics, what are best practices in the industry, pulling in best practices from other businesses, constantly looking at opportunities to basically take over other mom and pop businesses and roll them in. So Walmart, what are they into now? They're into banking, right? They're into all kinds of services. They have pharmacies, they have clinics, they have optical centers, all that. They've pulled that in. And so we also have to function in that very, very same way. But here's the kicker. With the changes of the ACA, and not only the ACA, but the changes that were a result of the entire Health Reform Act, we not only have to be super Walmart, but guess what we now have to become as a health system? I heard it. We have to be a Sam's Club. Right? So Sam's Club, does everybody get to go to Sam's Club? No. You walk in and you got to have a card, right? And if you have that card, then you can get services, you can get products at a super discount, right? And so the way you become Sam's Club is really the same situation that we talked about Walmart. You have to have greater power. You have to have a larger organization. You have to expand your reach, and you have to be able to offer services at a lower price than anyone can possibly do. And when you think about it, none of the mom and pops, none of the other stores can really compete with that volume that is being sold at Sam's Club. And so in a very simplistic manner, that is what we're really looking at as a system, being a great super Walmart and then also having certainly that Sam's Club mentality. Because what's going to happen is that narrow networks are going to take over every single state. And I know David Carmouche is here in the audience, and certainly, Blue Cross and others, if you look at what's happening across the country, you're either going to be in or out. And you're going to be in if you have high quality and low cost. And so the folks of the past, the providers, the physicians, the hospitals that were the winners were the ones who negotiated the highest rates. And they won. Well, now that will actually be something that will be a detriment to those folks being successful going forward. You're going to have to be a lower cost provider.
We always historically have seen physicians practice well into their 70s. They could have a slower, more moderate office practice, provide services, but with the increasing costs, the increasing difficulty in operating a business, we are not seeing that anymore. Physicians are starting to retire much earlier. And of course, one thing about the workforce issue is that we need to have better training. And for the first time in the last recent history at LSU Medical School, I can tell you that we now have medical students who could not match an internship or a residency. And it reflects not a Louisiana trend, but a national trend. And as the Affordable Care Act decreases monies available to graduate medical education, where will our doctors in training come from? We reflect that concern, and we constantly express it to people who will listen to us. With regard to the expansion of Medicaid in Louisiana, help me, I'm not sure why it's working. We don't believe it is the time. We expressed great concerns to Mr. Greenstein and to the governor when they began the rollouts of Bayou Health plans. We told them that these were not ready for prime time. We were very concerned that there would be many problems with them. Well, we know that there was much problems in both their implementation, their honesty, their forthrightness, and we see very much difficulty in all of these plans, and they're all trying to do a good job, all of these plans. But for example, in just my specialty, we now have, instead of one formulary for Medicaid patients, we now have 5 formularies for Medicaid patients. Every formulary is different. As an obstetrician, it would be really easy to say, I like this one prenatal vitamin, I'll write it for all my patients. No, because if you're on this plan, I have to give you that prenatal vitamin because the prenatal vitamin that's on your plan is not covered by your pharmacy, so I have to change it, and it is becoming a nightmare. We are working at the Medical Society with the medical director of Medicaid to come up with some solutions to these issues, but they are being very much driven by the type of plan and the plans themselves. Because whether you're a cost-sharing plan or those kind of things, you have different incentives on how you handle your drugs. These provider networks are currently strained. You find many hospitals having so much Medicaid patients that they really are finding it difficult to continue to expand because the reimbursements are so low and the ability to do business in a profitable way is decreasing. And I know one thing about Walmart, and I know one thing about Sam's, and I know one thing about Costco's. They do not sell quarters for a nickel and stay in business. Hospitals have thought about that. I remember when the HMOs first came into play, oh, we'll discount the price, but we can make it up on volume. I think we've all learned that that lesson is fallacious. And I think it's now time for us all to say whether you're a provider as a physician, a provider as a nurse practitioner, a provider as a hospital, we have got to be able to justify our costs and be able to recoup our costs, if nothing else, to provide those services. Hence, you've heard the talk about increasing purchasing power, the large systems can bring in the hospitals, and we have to figure out a way to keep those kinds of things available to physicians as well.
These are some of the issues from an employer perspective as we look at the ACA. The first one is interesting that I have down on the page is actually impacting unions and Cadillac plans. They've worked all these years to get the health care that they wanted for their employees. And now in the not too distant future, those plans are going to be taxed at a very high rate. Now you're going to start seeing allies of the administration say, hey, we got to do something different about that because we don't want to take those plans away from our employees. It's good to have some allies out there. Since employers, big change, unintended consequence, we believe, since employers have really no obligation to dependents, yet access to affordable qualified care to the parent eliminates subsidy eligibility for dependents, there could be negative consequences in terms of dependent care. We've all noticed that many plans across the country today have eliminated what? Spousal coverage. Not covered under the Act, unintended consequence. And so the affordability issue only applies to whom? It applies to the employee. So what I charge the employee is certainly something different than I can charge the family. So I can shoot that rate up for the family. They can't go to the exchange and get a subsidy because the employee qualifies. Their plan qualifies. Unintended consequence. Everything about the ACA defies all prior rules and principles of underwriting. You cannot go out and say, we're going to give you this benefit, these 10, 15 benefits at 100%, and say your costs are going to go down. That's not going to work. It's becoming clearer and clearer, and we talked about it again early in our wonderful keynote address, that individuals that join the exchanges will likely have to change their physicians change their plans, and then experience a much longer wait.
It is not fun to be in the business of primary care today. It is, thankfully, we have dedicated physicians that love what they're doing, are good at what they're doing, and care about their patients. But we need to help them, and that's what we decided to do. So we're going out and talking to physicians and saying, we're not going to just send you a letter saying we need these things. We'll help you do that. We'll embed a nurse practitioner in your office to help you at our expense. We'll put a nurse navigator in your office to help you with your patients to make sure that they're getting to the right place, that you're getting the information. We're trying to listen to our physicians to see what are the challenges of meeting these new requirements, and how can we help you get that done? How can we provide you with that help? Instead of sending you a letter saying, can't use this drug, you have to use something else, can we have a pharmacist go through it and sit down with you and try to help you through that process and understanding, and work as a real team together? Let's listen to what's going on with the patients. We tried this now about 18 months ago is when we went into this program. And we've had tremendous results. In each market, we selected 1 or 2 physicians to pilot it with. I have to tell you, when I first went to talk to them, a lot of what I got back was, I didn't go to medical school to have a nurse practitioner come in and see my patients. I get it. I wish I could put a doctor in your office, but I can't find them. So we're going to try to do the best we can. And those physicians that decided they would humor me and try it for 6 months and see if it worked, saw that there was a balance in the office. There were patients that they could use the nurse practitioner to help them with that would free up their time to spend with other patients that were more complex, that needed their help, so that they could see them more often. And what we're looking for is to have histories and physicals done on the patients each year so we catch things early, screenings that need to be done so you can meet those quality measures, post-acute care discharge visits so that we can make sure the patient understands what they're supposed to do in this day of hospitalist, where sometimes all the information doesn't get back to the primary care in time. A navigator in their office to make sure the patient gets to the appointments they're supposed to do and the information gets back to the primary care office. Home visits if the patient cannot come into the office, that the nurse practitioner can do for them. But it's a team working together and working with our primary cares and with our specialists to make sure the patients get what they need. We've seen tremendous results with that, and by next year, we expect to have the program rolled out to all our primary care physicians. And I truly believe that this is what we're looking at in the future, is more partnerships, payers and providers. We don't have all the answers. It's very difficult sometimes. You go in and talk to a doctor and you say, I have a concept. I'm not quite sure how the plan works. I need your help. We need to figure this out together.
Remember what we're doing here. We are a nation of 316 million people. At some point, every one of those 316 million people are going to seek health care, right? Or as my dad keeps reminding me, none of us are getting out of here alive, okay? So when these people seek health care, what is the Patient Protection and Affordable Care Act doing to their choices? What is it designed to do, and what is the actual impact going to be? So what I did to demonstrate this, it took a year, by the way, so be impressed, was define what I call the healthcare financing funnel. If we just take one of those 316 million people at random and we drop them into this funnel, let's see where they land as they fall through. Now, today, there are roughly 160 million people who get their health insurance financed by their job, either through an employer plan or through a spouse's plan. That's in excess of 50% of us out there are actually dependent on our labor to have health care, right? But what happens to the rest of the 316 if they're not eligible for an employer-based program? Well, they fall down to the next layer I call the government layer, all right? Now, PPACA was not written in such a way that it was to diminish the government layer. In fact, the original intent was to beef that layer up quite a bit so that it would be harder to slip through. But because of some miscues by the administration, we could argue 26 states are not playing ball, all right? And Louisiana is one of them. So now what happens is, if I'm not employer eligible and I'm not government eligible, and notice, if I add those two up, I'm well short of 316, right? Well short. Then I start falling again. How far do I fall now? I fall into the individual marketplace, or what I like to call the wild, wild west of the health insurance market. Now, why would I say that? Well, to put it simply, if I'm eligible in this layer or this layer, I have a guarantee of coverage. If I'm eligible for an employer system, I don't have to prove insurability. It doesn't matter if I'm sick or not. They will take me. Likewise with government programs, right? There's no insurability required. If I'm eligible, I'm in. But in the individual marketplace, you've got two things that are working a little bit against you. Number one, you got to prove you're healthy and a good risk to get a policy. And number two, you have to pay 100% of the premiums out of your own pocket. So when the designers of the act were building the stopper on this funnel, which is actually healthcare.gov, when they get to the bottom of the funnel, what will they find there? Well, they'll find individual insurance that does not require them to prove insurability. In fact, healthcare.gov will not ask them a single medical question, not one. And they will be, depending on their income, showered with federal dollars to help them pay for their premiums. Not only that, there is a second layer of federal assistance. If their cost sharing is too high, if they can't afford their deductibles or copays, there's even a mechanism in healthcare.gov that will buy down those cost sharing to make it as low as zero. And I'm going to show you some real examples of that. So when you're thinking about the act, keep in mind, there's not enough money on earth. Even the Fed couldn't print enough money to route everybody from here to here. All right? You're talking $1.5 trillion a year. It's just not there. Likewise, the government layer we think will get beefier over time, especially as more seniors, baby boomers, age in. The peak of the population boom in the 50s was 1955. If you throw 65 years on top of that, you find that 2020 is the max year for people aging into Medicare. So we've still got a few more years to go with the government layer growing even more. So kind of keep this in the back of your head as I'm showing you what healthcare.gov can do. All right. Come on, baby. There we go. Because now every American, this is the empathy part, in case you missed it. Isn't it terrible when somebody has to tell you, be empathetic? It's like, nah, it's not nice. This is the part of the presentation where we ask the basic question. Do I as an individual have to have health insurance coverage? Now, anybody can tell you, if I'm going to offer health insurance to people and I'm going to heavily subsidize it and I'm not going to ask you any health questions, that the first guys in line are going to have some very interesting health conditions, right? We know that. And they're going to be expensive to take care of. So if you can't draw an appropriate population of healthy folks to help subsidize them, the whole thing will crash very quickly.
Hey, what would you say are the biggest challenges that people are facing now because of the Affordable Care Act?
Well, I think people have to make a decision about their own coverage. We see now increasing concerns about people losing coverage that they've had in the past and have liked. They thought they, in fact, could keep it. That's what they were promised, but we're finding out increasingly that's not the case. Again, I think prices, whether or not people can afford coverage, how that will go forward, and what choices they have available to them, I think are all issues.
I think the biggest challenge with the Affordable Care Act is that it is focused on preventative care, and that's a big change. Unfortunately, it is a change for the providers and for the members, and sometimes when you're talking to them, you know, any change is a challenge, but ultimately it's the best thing about it. You know, the road getting there is bumpy, as I've said often, but I think that ultimately as we focus on preventative care and managing care early and getting better outcomes, we're going to have much better healthcare outcomes for everyone.
I think the greatest challenge that we have as employers is unknowing. The Affordable Care Act is evolving. We don't know what the final regulations are going to look like. And as you plan for the future, you would like to work from a stable background. And today, as a lot of the regulations are still evolving and changing, we really don't know what that platform is going to look like. So I think that's really the challenge that we have is how do we stabilize, or how do we get the platform stabilized in which to conduct business?
I think the positives are an attempt to try and reform the individual market to make it more affordable for individuals and small business. Certainly some of the insurance reforms that get rid of pre-existing conditions that make coverage more available to families. I think one of the negatives, of course, is the complexity, the issues that have arisen with respect to the exchange, and the sheer magnitude of the role of the federal government, I think, is challenged by some.
5 years ago, would you have predicted the Affordable Health Care Act?
Well, I'm not sure I would have predicted the ACA, but I would have predicted that we were going to move forward with some changes in the insurance industry and some attempt to expand coverage.
Okay, what are some predictions you have?
Again, I think most of physicians will see more patients as a result of the Affordable Care Act, but they'll get paid less per unit of work.
I think that the thing we've got to realize is that the providers are taking the biggest impact on this, especially the primary care docs, but all doctors. There's a lot of change going on in their offices and in the way they practice in the delivery system. So we need to be sensitive about that. And for myself and all of us that are payers, we really need to work together to develop partnerships to make this successful.
Well, in terms of affecting people, I think the question really becomes how many people are able to sign up at the end of the day. I think due to the delay, I think the numbers that the federal government projected of actually enrolling and being a part of it are way overstated. And so certainly for this first year, I anticipate that there will be far fewer people insured than anticipated, which is going to put a lot of pressure on providers because we get the benefit of all of the cuts from Medicare and Medicaid DSH this year. And so it's really going to be an interesting year for providers across the country.
I think Obamacare is here to stay. I think there are going to be some changes. We've already seen some slippage in the employer mandate. We're going to see some changes in the individual mandate as well. There are some amendments in Congress right now to actually change some of the structure of the ACA, and as I was talking about the stability of the platform. And then lastly, who's going to care for those 42% of Louisianians who are now going to become eligible for Medicaid? That's going to be a bit of a challenge as we attempt to practice on a go-forward basis.